Dear students, you're welcome for this lecture. My name is Kiden Robina, and I'll be taking you through ectopic pregnancy, or what can also be known as extrauterine pregnancy. So right there we have a picture the uterus, and the first how normal pregnancy should do. Uh, uh, After fertilization of the egg or the ovum, it is moved, or it moves until the endometrium, then which by then is known as mesoderm, then it is implanted there. This is the normal process. Whereas in ectopic pregnancy, example of ectopic pregnancy where they fertilize the egg is implanted in the fallopian tube. So in ectopic pregnancy, the highest number of ectopic pregnancies are implanted in the fallopian tubes. But also there are those that can be implanted in the ovaries, even in the abdomen. So in the abdominal cavity. So let us look at them. Now, when we talk about ectopic pregnancy, here we refer to the fertilized ovum being implanted outside the uterine cavity and normally in the fallopian tubes. So common sites include fallopian tube, which constitutes 90%, like I stated before, that it is the highest percentage. And specific locations include fimbriated end, ampulla, which is common, isthmus, which is very dangerous in case it occurs there because it is very small, it's a small area, and the interstitial part. Then other common sites apart from the fallopian tubes, sites that are less common include ovary, which is 0.5%, cervix is very rare, but if it happens, very minimal percentage. Then abdominal cavity is 1%. Fertilization occurs in the distal third of the fallopian tube. After fertilization, the zygote begins to divide and grow. However, if an obstruction is present due to various factors, or what we can say predisposing factors, such as, for instance, if someone had an infection and was not treated, then there was some residues that are formed in the fallopian tubes, it can block the movement of this fertilized egg. So the zygote is unable to travel through the fallopian tube. As a result, it becomes lodged in the constricted area, leading to implantation at that site instead of the uterus. Predisposing factors include tubal damage from infections such as gonorrhea and chlamydia can lead to pelvic inflammatory disease, or what is known as PID, a serious condition that causes inflammation and scarring of the fallopian tubes. So in case this happens, then it is very difficult for the fertilized egg to move. So it will end up being implanted in the tube. So this scarring can block or narrow the tubes, preventing the fertilized egg from passing through to the uterus, resulting in an ectopic pregnancy. PID often goes undiagnosed or making regular screening prevention. The second factor can be peritoneal adhesions from surgery. Peritoneal adhesions are bands of scar including around the fallopian tubes as a result of previous surgeries. These adhesions can alter the structure or function of the fallopian tubes, creating an environment where a fertilized egg is more likely to implant outside the uterus. So the risk increases with the number or complexity of abdominal surgeries, and the adhesions may not always be detectable without imaging or surgical exploration. So this is likely what may happen in case surgeries are done. More so if repetitive surgeries have been done, they can create scars, or they can alter the structure of the fallopian tubes. As a result, if the structure of the fallopian tube is now abnormal, the fertilized egg will not be able to act in the normal expected way. The third predisposing factor is endometriosis. Endometriosis is a condition where tissue similar to the lining of the uterus grows outside the uterus, often on the ovaries, fallopian tubes, or other pelvic structures. This abnormal tissue growth can cause inflammation, scarring, and the adhesions, which will block the fallopian tubes. As a result, the fertilized egg may become trapped and the implant in the tube or another abdominal location, which can lead to ectopic pregnancy. The fourth predisposing factor is congenital. This can in the or function of the fallopian tubes, such as tubes that are too narrow, blocked, or malformed. Such conditions can impede the normal transport of a fertilized egg to implantation tubes or other ectopic sites, maybe like the abdominal cavity. So these abnormalities may be genetic or due to prenatal developmental issues, and they often identified during that is when this can be identified. It is very difficult to identify before this happens. The fifth predisposing factor is previous ectopic pregnancies. This is often because the underlying causes, such tubal damage, adhesions, or congenital abnormalities, may persist or worsen over time. After an ectopic pregnancy, the affected fallopian tube may be damaged or removed, especially if the person undergoes or if the person experiences rupture uh, ectopic, which normally actually happens, and it requires surgery, or surgery can be done even when the ectopic pregnancy has not yet ruptured. So it creates damages, further complicating the passage of a fertilized egg. Women with a previous ectopic pregnancy require close monitoring in subsequent pregnancies to detect and manage potential ectopic implantation early, as the risk can be as high as 10 to 20% for recurrence. So they really need to be monitored closely. Signs and symptoms. Let us look at the signs and symptoms of ectopic pregnancy before rupture. be additional signs that can indicate that the person may not be carrying a normal pregnancy. So, one of the signs and symptoms is abdominal to 3 months, abdominal pain, slightly enlarged uterus or mass on one side. So it depends on where it has been implanted. The mass can be identified around that area where it has been implanted. Then after rupture, the mother will experience acute symptoms: abdominal pain, fainting, vomiting, vaginal bleeding, cold sweats. Then the mother will also have clinical signs such as weak pulse, low BP, tender abdomen, cervical excitation, and anemia. Chronic leaking, persistent lower abdominal pain will be experienced. Amenorrhea with irregular dark brown vaginal bleeding. So this can happen when the pregnancy is ectopic, but the mother has some bleeding, and normally, because of course the location is not the normal one, so the mother gets that chronic leaking. So here the mother will experience amenorrhea, but she will have some irregular kind of bleeding, which comes per vagina, and in most cases it is dark brown. Then she will also be feeling possible nausea and vomiting. Differential diagnosis of acute ruptured ectopic pregnancy. What are those conditions that may be mistaken for ectopic pregnancy, or are those conditions that ectopic pregnancy can be mistaken for? Here we have acute pelvic inflammatory disease, ruptured gastric or duodenal ulcer, fulminating appendicitis, torsion of the pedicle of an ovarian cyst, acute pyelonephritis, rupture of corpus luteum with the intraperitoneal hemorrhage. So those are some of the conditions that can be mistaken for ectopic pregnancy, or ectopic pregnancy can be mistaken for them. So management: diagnose early to avoid complications. So the early diagnosis of a condition of ectopic pregnancy is very important for complications to be avoided. Then surgical interventions, which may include salpingectomy or repair of damaged tubes, address underlying causes like infections or adhesions. This needs to be addressed and managed. So, what are the important things that we should know? Always refer patients to hospital on the slightest suspicion of an ectopic pregnancy. Severe collapse with little or no warning signs may occur if the zygote is implanted in the isthmus, often without a history of missed abortion. Investigations. Investigations such as paracentesis can be done to detect free clotting blood. Then caldocentesis can also be done when which can indicate positive for dark blood. Then hemoglobin estimation and group cross matching can also be done, especially when the mother is being taken for surgery. Then ultrasound, which confirms diagnosis of the ectopic pregnancy. So management, we continue. The initial step is to admit all suspected cases for emergency surgery preparation. Here, emergency laparotomy may be done if the ectopic pregnancy is ruptured. Then laparoscopy or laparotomy for unruptured cases with the tube preservation attempts. For example, we can talk about the salpingostomy. Preoperative care, NPO status, nil per os, oral intake should be given to the mother. Then IV fluid, resuscitation, blood for cross matching, blood transfusion if needed, monitor vital signs and the signs of shock, then informed written consent and the pre-operative checklist. Then post-operative care, here we shall look at monitoring vital signs and the symptom signs, monitoring vital signs and signs of bleeding. Continue nil per os. The mother should not take anything until the boil sounds have returned. Then correct anemia with the hematinics. If the mother has anemia, she should be given things that can help in generating blood. Then antibiotic prophylaxis can be given to the mother. Pain management can be done using analgesics, and we also encourage early ambulation. Patient education, future infertility risks should be stated clearly to the mother. Then the risk of repeated ectopic pregnancies, contraceptive use to delay pregnancy for 6 to 12 months before she conceives again, nutritional and the dietary counseling, importance of follow-up visits. Complications and outcomes, recurrent tubal pregnancy may occur in about 10% of cases. Infertility can occur in about 50% of patients. Then normal pregnancy can be also in about 50% of cases. So thank you for being part of this lecture. God bless you.